So let me say, first of all, congratulations for you all being here. I'm not sure if you are aware, but this session sold out within the first 24 hours. 15 people tried to get in the next day, so well done to you for taking the initiative to be here. And also well done to you for being alive and alert at this hour of the evening. So I'm just going to get you all to plonk all your gear on the chair, have a stand and a stretch. You've already had a wee, so that's good. Who here has ever had a patient, a client in their clinic that has complained of plantar heel pain? You have done everything that you know what to do, and still you haven't got the result, or they haven't got the result thereafter. Who's ever had that experience in their professional career? Great, thank you, we all have. Haven't got enough limbs for the number of times they should have happened. The beauty of this evening, some of the images that have been explained by Sean and Neil, and the cases that have been presented, I sit here and I think just how phenomenal the technology, the ability. Most of you are all too young to realise this, but there was a time when MR imaging didn't actually exist, and I was actually a professional practitioner at that time. What I want to go through with you tonight is probably stemmed from some very wise modern philosophers, also known as Monty Python. And because I want to take you on a little bit of an about-face flip. I think it was Monty Python. But anyway, imagine this scenario. There are two guys in the middle of the Sahara Desert, explorers. They're clawing their way, dragging themselves along the sand dunes. Vultures are circling overhead. I don't know if they have vultures in Africa, but anyway, the birds of prey is there. Two guys, they're just clawing. And one looks at his mate and says, "Mate, I can't go anymore. I'm done." And the other guy looks and says, "I know what you mean. Listen, I don't know. But I was just wondering, if you're here and I'm here, who's filming this?" The camera goes back, and there's this whole film crew, all shaded, they got food and drink and everything, so they get up and go, "Oh, this is fantastic." So they're drinking and rehydrating themselves. And hang on a second, if we're doing this, who's filming this? The camera goes back again, and then there's another whole film set here. And the reason why I point this out, I just use this story as an analogy because what we've been doing with the tremendous diagnostic imaging is zooming right in. What I'm going to ask us to do now is just kind of take the camera back a little bit and let us have a look at some of the more global elements, and particularly us as podiatrists, what are the things that we could do in our clinics that actually might help us steer or make the decisions to refer to or to get some diagnostic imaging actually happening. So the first thing we'll need to look at, that's your third glass, I'm a little bit worried. One more? Let's go forward. Yeah, no, okay. We apologise for our technical break in transmission. No, the arrows, go with the bloody arrows. Yes, that arrow. Oh, okay, so our field of expertise and interest with biomechanics. Who here has heard of the Columnar theory of foot function? Just show of hands. Great. Who here has never heard of that at all? Okay, great, thank you. Who here has heard of the beam principle of foot function? Show of hands. Or fewer, okay, great. Where from? No, don't have to answer that. All right, so I'm just going to skim through another biomechanical theory of foot function. Are you excited? No, quick, lock the doors, Emma, because this is the part where they'll run out. Okay, this, as far as I'm concerned, is probably the one theory or principle of foot function that you need to be concerned about. All the others are rubbish. This is the one that's actually going to be clinically relevant for you. It's based on this simple principle. And that is that the foot anatomically is divided, or can be divided into two beams. Now, I know some of you have heard of the medial column, lateral column, and sometimes refer to the foot as that, as those structures. In engineering terms, columns are vertical structures. Beams are horizontal structures. So technically it is correct to call them beams, not columns. Now, the medial beam consists of these bones here highlighted in purple. So we've got talus, navicular, cuneiforms, first three rays. Lateral beam is all the other bones. And essentially the way it works is the lateral beam is the part of the foot. Leonardo da Vinci, we were talking earlier this evening, he described the foot in its biomechanical design. The lateral beam he referred to as piedi statico, so the static foot, and the medial beam, the piedi dinamico, meaning the dynamic foot. So you have the static foot, the lateral beam, and then the medial beam. The lateral beam would take the body weight, and the medial beam would be the part that would adapt to the Earth's surface and then turn into the windlace mechanism to propel us into the next step. But essentially, anatomically, there's a relationship where there are two beams. Now, let's see what happens when you press the button next. Plantar heel pain, plantar fasciitis. Which structure, when we've got the plantar fascia, which band of the plantar fascia is typically the band that gets irritated, inflamed, or stressed out, symptomatic?
Medial.
The medial. That's what we were taught, certainly in our generation, John. The more recent literature suggests that it may actually be more of the mid-band rather than the medial. Also, now the literature also shows that in 12% of cases, there may not actually be a medial beam of the plantar fascia, a medial band of the plantar fascia. So anyway, whether it's the medial band or the mid-band, the same principle still applies here. So diagrammatically, we've got lateral beam, medial beam. The origin, if we're going to take the medial band of the plantar fascia, the origin is in what part of the heel? Where would you say the origin of the medial band of the plantar fascia or the plantar fascia is? So it's on the which beam? Lateral, okay. Just so I know that you know what I'm referring to here. This is lateral beam, this is medial beam. Origin, plantar fascia, is on which beam? Lateral beam. Good, thank you, all right. And the insertion is on the medial beam. Okay. So we actually have this structure that's probably the bane of our lives as far as non-recalcitrant conditions that are on two different beams of the foot. Now, what would happen if, imagine this, imagine the talus for some reason actually shifted or displaced in an anterior direction. If that happened, what bone would it push into? The navicular, which then pushes into cuneiforms, which then pushes into first, second, and third braids. Okay, so we would literally get a shift of the medial beam relative to the lateral beam. Make sense? Okay. If we get a shift of these of the medial beam relative to the lateral beam, what would that do to the tissue tension of a structure that connected between the two beams? Increase or decrease? Increase. Are you sure? How many think increase? Okay. How many think decrease? Okay. How many don't know? How many don't care? Literally, if you get an increase in distance under weight-bearing force, an increase in distance will lead to an increase in stress on those tissues. Now, okay, so that's a theory, isn't it? That we can get a shift of the beams relative to the other, putting tension there, all right, that would lead to some inflammatory reaction on the relevant structures that are affected. Who here thinks that the medial beam could actually shift relative to the lateral beam? Who thinks that's possible? Okay, how many think it's not possible? Okay, how many don't know? Okay, that's the majority of fantastic. That being the case, everyone, shoes and socks off please right now. Air conditioning's on? Yeah, okay. Shoes and socks, right off. Okay, great. Now, how can you tell? The rest of you got to come up here and work out, how can I see, haven't even touched them, or I haven't even talked to them. I'm looking forward to that. How do I know that they've got a displacement of medial beam relative to the lateral beam? You can have a close look at them. This Peter's right foot is a classic example. So is, I'm going to say it's Angelo's right foot. Because I'm good like that. The case that Angelo actually showed up and on the screen also had this clinical sign. So what is the clinical sign? Anyone got clues? Especially if you know, if you've seen this before. Oh, she's hiding. Have a look at the toe parabola. Meaning, so if we have a look here, we got 1, 2, 3, drops back to 4, 5. So literally, if the medial beam and the first 3 rays have shifted over time, they'll shift and you'll get this drop back to the 4th and 5th. Now, it might be toe length difference there as well, but see here, got 1, 2, 3, boom, 4, 5. Then there's more subtle versions. So you were maybe on that side here, yes, on the right, not on the left, maybe on the right. This one here, maybe, it looks like a bit of a toe thing, so that's a good example. This one here, even here, you see 1, 2, 3, 4, 5. This one's like kind of this one's kind of a maybe-ish. Not as classically obvious as some of them, but this is a clinical sign that can give you a clue as to what to look for if you have a case of plantar heel pain that's not responding to your treatment. More will be revealed in just a few minutes. Okay, so could it be just the shape of these feet? Yes, that's possible as well. But one of the things to be mindful of is this is a clinical indicator. And there are several other clinical indicators before we need to get some imaging. But if your clinical indications suggest that there might be a shift of the medial beam to the lateral beam that is putting additional stress on the plantar fascia medial band or the mid band, then the test that absolutely confirms whether there's a displacement of the medial beam relative to the lateral beam comes through weight-bearing plain film x-rays. Now, let's have a look at the next one, please. Here we have plain film x-rays, just to make sure we're oriented in the right position. We've got the leg coming up here, we've got the foot coming down this way. This is, which bone is this? Talus, good. That makes this bone here, but okay, it's all right. So this joint space that we're seeing through here is what? Cyma line, C-Y-M-A, okay. What does cyma stand for? Latin for snake-like or serpentine. So we've got this serpentine line or snake-like line between the talar-navicular joint, calcaneal cuboid joint. Weight-bearing x-ray, lateral view in a normal, well-balanced structural biomechanical position of biomechanical integrity, there will be a smooth continuity between talar-navicular joint, calcaneal cuboid joint. So far, so good. If the talus those shifts anteriorly, which then, as we've discussed, bulldozes into the navicular, into the cuneiforms, we get the shift of the medial beam relative to the lateral beam. Here's the talar-navicular joint, here's the calcaneal cuboid joint. We literally get a shift this way of the medial beam and the lateral beam. And it breaks that cyma line, that smooth continuity. Can you see that here? Okay. How many can see it? Okay. How many cannot see it? Okay. I'm happy to explain it out further. But what happens here when you get this anterior shift of the talus, and it has that bulldoze effect, can you see what's happening up top here on the navicular? What have we got? Yeah, it's lipping. Why? Because the talus is just jamming every step. It's the body's response to that excessive force. Okay, so this is an example, a classic example. If you have a plantar heel pain case that's not responding to your conventional treatment, investigate to see whether there is a shift of the medial beam compared to the lateral beam, so that you can tell whether there's any abnormal tissue tension on the band of the plantar fascia, if that's the symptomatic sign. Make sense? Okay. I don't care how accurate the cortisone injection is, or how much padding you've got, or what control you've got in the footwear, or what assistance through orthotic devices. If you have a mechanical constant overloading of that medial beam relative to the lateral beam, it's not going to help your other treatments. It's literally going to undo your other treatment approaches that are undoing or that are affecting the symptoms that your patient is feeling. Any questions at this stage? Make sense? Okay. Now, so I asked the question, does the talus actually shift or displace? What is the most common injury that you have your patients report to you that happens to their ankles?
Lateral ankle sprain.
Lateral ankle sprain, inversion sprain. Who here has ever had a patient in their clinic that has had a history sometime in their life of an injury of an ankle sprain? It's really common. Okay. What structure is the very first structure around the ankle that is compromised, stressed, or weakened with an inversion sprain?
ATFL.
ATFL. It's been documented in 92% of ankle injuries, it's the ATFL that gets damaged or compromised. Here's the kicker. What is the number one purpose or function of the ATFL?
Stop anterior shifting.
Stop the talus from shifting anteriorly. When I learned that, I went from an innie to an outie. Just like that. It's like, really? You mean, now, when you go back into your clinics and you find those patients who have heel pain that's not responding, check and see if there's a displacement of the talus. Check and see if they've had a history of ankle injuries. Because once the talus inversion sprain, ATFL compromised, talus will shift. Normally what the body does is utilize muscles to hold, pull, or restore positions whenever it can. Which muscles are going to be recruited to pull the talus back? None. There are none. You've got some structures around the joints, but none that will specifically be able to restore the talar position. So then it becomes a chronic adaptation, tissues all adapt, and you can have literally months or years later when cases like plantar heel pain then show up and become a problem, which the underlying cause. That's what I mean by taking the camera back. Let's just have a look at what is the cause of the problem that could be leading to the symptoms. How good's that? Who here has learned something tonight that you didn't know before you got here? Good job, accomplished. All right. Who here learned something from me? Because I know you learn a lot from these two guys. No, it's just that. Okay, medial beam, lateral beam. Hang on a second. He was talking earlier about neuromas. Which intermetatarsal space is the most common intermetatarsal space that neuromas form? Between 3 and 4. Hang on a second. That's between medial beam, lateral beam. You mean that shifting beam could aggravate those neurovascular structures in between those two? And that could be coming from the... Listen, I never treat the talus because it's a neuroma. That's where it's stuck in the injection. Hey? What about tib post tendinitis? Where does the tibialis posterior tendon insert into? What's it attached into? Navicular. Now, that's the medial beam. It shifts anteriorly. That means there will be further tissue tension. What body says, let's pull it back, try and pull it back. muscles only this big, body's this big, it can't counteract that, but it doesn't stop it from trying. Maybe that could be why those post-tendinitis conditions don't always respond as well as they should. And where does it all start? What's this bone? Talus. Do you know what talus was called before it was called the talus? Some of you know. Astragalus. So like Oscalcis is now calcaneus. Astragalus. What does astragalus mean? Astra, crappy hole in your heart. Astra is it's Latin for star or central star, and gallus is galaxy. So astragalus actually means center of the universe. Center of the universe. Our pioneering forefathers deemed for skeletal structural stability, the talus was so important that it was christened center of the universe. And it's our job to look after it. You cannot have a skeletal, harmonious, well-balanced skeletal structure if the talus is shifted or displaced. Anatomically, engineeringly, it's physically impossible. As soon as it shifts, everything will compensate. Cannot not compensate. So, take-home lesson is, plantar heel pain that's not responding, what are you going to check for? Check for medial beam, lateral beam, check for the talar position, most important. Only do one thing from tonight is know to check for the talus, and then what you'll do is you'll grab some referral pads to Fowler Simmons, and what you'll be writing down is weight-bearing plain film x-rays, normal stance of gait, both feet, make sure you check. So there's a $20 tip for if you get these reviews done, reports done to me. Oh, then the other thing is, make sure that you put down there that the biomechanical assessment will be conducted by a referring podiatrist, because the radiologists, they don't this stuff. But now two more do. Hey. But this is a simple test. Great diagnostic test, and this is, we get a lot of people referred to us because they've tried everything else. Our focus of treatment would now be working on the talus to mobilise or work it back into position, and then help use the peripheral muscles to stabilise and strengthen and maintain that correction in the long term. There ended the lesson of
My quick question would be,
Please.
what would the difference be, or what would your personal opinion be on something as simple as creating a gastroscleral stretch to enable the part fascia to handle washing style stress versus shifting the tails back anterior?
Great. So you're saying that you free up the structures? Yep, so that the talus can shift even further?
So add flexibility to it and see, would there be, do you have any personal opinion on that?
Yeah, exactly. What will happen is the talus shifts even further and collapses further. And actually,
So we need to look
you can get some
sensitive.
temporary, you can get some relief. It's like, stretch, it feels good, but it's temporary at best. It really, literally, in terms of physics, the vectors and forces and moments are there. It will be a symptomatic relief at best. It hasn't, in my experience, shown to be able to get long-term correction and maintenance of that. Any other questions?
How long would a mobilisation last though? Like, so you try to put the talus
Great question.
posterior and then you walk and then...
Yep, all right. So the idea that talus is out, you put it back in, is not how the body works. Physiologically, the tissues, the connective tissues, particularly the collagenous tissues, they need to be restored and be able to get them to adapt to a new working position to hold them in. The way the body does that is our cells are literally turned over at, literally our old cells get replaced with new cells. Depending on the tissues, that happens at different rates. But we get a new stomach lining every 7 days. Muscular and skeletal muscle cells take around 12 to 14 days. But collagenous periarticular tissues around joints take around 6 weeks. Oh, 6 weeks, really? Is that what it really take? Well, think of a decent ankle inversion sprain. How long does it take for that to really fully heal? It's typically about 6 weeks. I think you'll feel better and working and functioning within 2 or 3 weeks, depending on the severity of the injury. So what needs to happen to us, so what I'm getting at here is you've got to get the joint restored and then get those cells to replace themselves to adapt and hold and maintain that. So it's not like something is out and you just clunking it back in. And that's a gradual process that takes time. And we found in our experience that if you spend 6 weeks restoring the position and then 6 weeks maintaining the position, then you get an excellent long-term result. And that gives the body the time and those tissues around the joints to adapt and hold for the long term. As we utilize other modalities as far as strengthening exercises, stretching the tissues that need to be stretched, the use of appropriate footwear, gait retraining. There's a whole series of elements that need to go into helping with that. But yeah, it's not a quick fix. The problem usually, unless it's an inversion sprain, an acute sprain of significant forces, this is a problem that usually happens over time. And often the underlying causative factors probably happen years or even decades beforehand. So it can certainly, it is a chronic condition as far as getting those connective tissues to readapt. Great question, thank you.
Okay, can I just ask the answer on the right?
Yes.
I mean, that person may have blood vessel issues, they may not, that's fine. But that person could quite easily have tip-post dysfunction.
Yep.
Okay, and that pattern is now considered as clearly a tip-post dysfunction, not we're getting chicken and egg. So if someone has long-standing tip-post dysfunction, they're going to develop a foot that looks like that. And the association with tip-post dysfunction and spinal fascial abnormalities is well documented. So we see that all the time. And that probably adds further weight to the theory. And I fully subscribe to this fine. But does it work? Can you explain the chicken and egg sort of side there? Because
yes.
If you're saying that's what's causing the tip-post dysfunction, where I'm saying tip-post dysfunction could cause this,
yes.
How do you work around that?
So what I would say is that you're wrong and I'm right because I'm not. But it works both ways. So and there is no clear answer in saying, well, yes, this is the definite cause. What I suppose from my anecdotal experience, what I found is that either way, you've still got to work on restoring the talar position. And then see if you can get some rehabilitation of tip post and do that. Kind of take the camera back, we're going to need to get that talus restored because the body can't do it on its own, it can only come from an outside force. And so, no, I don't have an answer. Seriously, I don't have an answer which one comes first, but the scenario you painted, absolutely, I see that all the time.
I reckon if it doesn't necessarily change the treatment.
No,
problems are the same, but you can use both.
Yep. Great. Any other questions?
Does anyone here know that Ted and I are related?
Stand, come stand next to me. Sure. We're in the land of the little people.
We are related. So. Weirdly, but we are.
Yes. So that's it. He comes to my 50th birthday celebration in Rome, and now he just claims me for everything. No. Right. Gentlemen, if I can get you to stand at Angelo here, particularly with that foot deformity that you've got there. I would like to ask you all to please thank Nat, who, she's gone, so she's obviously had a better offer, but the work that they have gone through to, yes.
This is Nat.
Thank you very much for your participation, your active involvement. I hope you have gotten some practical value out of the presentations this evening. I'm really thrilled that you've been able to experience our wonderful, our wonderful facilities here. Just 'cause I know. But certainly as far as quality diagnostic imaging, we can certainly recommend Fowler Simmons without any hesitation.
Where's your
It looks like, Michael, you're going to pass those out.
Yeah, I was just going to say, I mean, we didn't mean to keep here this night, so we really appreciate it. But you can see us from tonight as well, just from looking at some of the images, how much they get from it as well. Not only themselves personally as well, their staff, their ultrasonographers are second to none. They really are. They've got people who are physiotherapists who are now ultrasonographers who are, you know, as good clinicians as you can get as well. So some of the patient results I've had here, they make me look good often. So at the end of the day, the ability to refer to a group like this as well really is, it only benefits you.
Please join us and thank you.